Welcome everybody. We'll be waiting a little bit to let everyone into the webinar for a couple of seconds here. We're so glad you're able to join us today for our next edition of the 49er Industry Chats. I am Noemi Guevara, one of your hosts and the Director of Alumni Engagement at Cal State Long Beach. Before we start the session, I would like to let you know that this session will be recorded and will live on our website for future viewing, and it will be housed under the csulb.edu/alumni. And now I would like to introduce CSULB Council Member for CSULB Alumni, Lucia Koss, who is a graduate from the class of 1975. Lucia?
Good afternoon. I've got the pleasure of introducing our speaker today, who is Dr. Theresa Rohr-Kirchgraber. Did I say that right?
Perfect.
Is the Executive Director of the Indiana University National Center of Excellence in Women's Health. And she leads the mission of improving the health of Indiana women with an outreach program, statewide collaborations, and also by impacting policy decisions. She is a professor of clinical medicine and pediatrics. She has served as the chief physician executive of the Outpatient Center of Excellence in Women's Health, which provides primary care for patients with chronic diseases, eating disorders, and cancer survivors. She's served as president of the American Medical Women's Association from 2015 to 2016. She is an inaugural fellow and recognized for outstanding achievement in science, medicine, and academia. And she has served as a vice chair on the governing council of the Women's Physicians Congress American Medical Association. So Dr. Rohr-Kirchgraber is a proud 1984 alum of Cal State Long Beach, and she graduated with a BA in chemistry, and she's also graduated from, I hope I say this right, Weill College of Medicine at Cornell. She completed a residency in internal medicine in the University Hospital of Cleveland, Case Western Reserve University. And she is also a former CSULB Distinguished Alumni Award recipient. That was in 2016. So joining us from Indianapolis, Indiana, Dr. Theresa Rohr-Kirchgraber. It was a mouthful.
Thank you. And it's, you know, and it's a long introduction. Thank you for that. That was pretty impressive.
You're welcome.
So, do you want me to get started, or you want? This has been.
Yes, please launch in.
Jump in. This is great, though. I really appreciate this opportunity because it allows me the opportunity to be able to kind of reflect on some things and also to discuss what an impact being part of Cal State Long Beach has been on me and also on my career. I grew up in Los Angeles, in the Los Angeles area, Baldwin Park. I'm one of 8 children. I'm a first-generation college student, and we didn't have things like college funds. You know, when you have 8 kids, you're just happy to get out of the house, you know, much less to have anything to be able to sustain you after that. I chose Cal State Long Beach because I could afford it, okay? Let's be real. I was working at McDonald's and saving my money, and Cal State was close to where I grew up. It was a great campus, and it had everything that I was looking for. I wasn't sure if I was going to do theater or nursing or law, so I figured it had a little bit of everything and I could end up there. Went there, and at the time, the campus was about 25,000 students, but I still found a really kind of a small, close-knit group. I lived in the dorms, which there weren't very many dorms at that time, 1978. But I found it to be not only affordable, but also I had people that were looking out after me, which was really nice. And it was also close enough that I could get home when I wanted. Being one of 8 kids, and being the first to go to college, there wasn't a lot of, well, there was support. You go, that's fine, but not a lot of, here's how you do it. You sort of had to kind of find your own way for that. Initially, I started out thinking about law, and actually I believe my first major was for law or something. And then the more I took classes, the more I realized I kind of like the sciences. So then I thought, you know, I'll go nursing. I didn't know anybody who was a nurse or in healthcare field at all, but it sounded interesting. I had done some kind of CNA type work, so I thought that would be fine. And then I started working at a local hospital in Lakewood, partly because I couldn't afford to work and make money and volunteer for experience. So I found a way of working at the local hospital in the emergency room, you know, doing intake for folks. And that then gave me exposure to working with physicians and nurses and, you know, the whole gamut of healthcare workers. And during that time, I continued to do my undergraduate work. I took all the sciences I needed for nursing. And then after I got accepted into the nursing program, one of the nurses I was working with at Lakewood, Steve Wasserman, he kind of yelled at me the whole summer before I was supposed to start my clinicals. And he said, you know, why are you doing this? And I explained, well, I thought, you know, nursing would be fine. It looked like it was a great thing. And maybe I could eventually get a PhD and then get an NP and, you know, and he said, well, why don't you just go for an MD? And I was like, well, I don't know. I mean, nobody does that. You know, only 1 in 10 people get accepted. I can't do that. I don't know anybody. And pretty much he yelled at me the whole year and the whole summer. And he said, you know, if what you want to do is this type of work, then you really need to, you know, take the jump and go for it. And I was like, I just didn't think that I could. I mean, and I'm sure that's true for most of us. When we think about what we want to be when we grow up, there's always limits that we put on ourselves. And I didn't have the money. I didn't have the time. I was already, you know, halfway through with my education. And I thought, gosh, if I stop right now and try to get into medical school, I'll be 27 by the time I graduate. Oh my God, that seems so old. And after working with him and having him yell at me that whole summer, I thought, you know, maybe I should. Let me go ahead and apply. Let me go ahead and switch everything. And if I don't make it after 3 years of applying, then God's telling me to do something different and I'll go back and go to nursing school. But if I don't, by the time I'm 27, if I haven't done it, then I'm going to really be mad because I could have been done by then. Luckily, I only had to apply one time. and I chose chemistry because, quite honestly, it was the one major where I could already use some of the things I had, plus do the prerequisites and get out in the fewest number of years. So I switched my major. It took me 6 years to get through. And luckily I got into medical school in the first try. When I first switched to thinking about pre-med, I got a lot of advice from people. Well, you're gonna have to transfer schools. You wanna go to a school. Well, you know, you need a bigger name behind you. And all of those things I really took seriously into consideration. And I realized, one, I couldn't afford any place else, number one. Number two, I had teachers at Cal State Long Beach that actually knew me. They knew my name. I mean, I could be one of 50 or 100 in the class, not one of 400 being taught by a TA. Plus, I had a fabulous pre-professional group. The Office for Pre-Professional Students was incredible. They helped us out tremendously. But there was also an organization that I got involved with called Chicanos for Community Medicine. And they were a like-minded group of folks too. People who were first generation, who were minorities, who understood what it was kind of like to not have a coat when you needed to go to interview in Boston and New York in the middle of winter. So that having that kind of group support was incredibly, incredibly powerful. So I'm grateful not only to my team at Cal State Long Beach, my professors and everybody else, but honestly, I'm grateful for the taxpayers of California. Because if you didn't have a system like this, where we could afford a college education while working at McDonald's, you wouldn't have people like me. I wouldn't have been able to afford school. And I also wouldn't have been able to change my major. I mean, if I was paying $50,000 a year for education, I wouldn't have been able to do it. So At the time, my decision to go out of state for medical school was mostly based on the fact that I saw myself living in California for the rest of my life. That was what I planned to do. I'm a native, and that's where I was going to come back to. So I thought I'd just leave for 4 years, figure out what it was like. And the cost was going to be the same for me, whether I went to UC Irvine or Cornell, which is the Weill College of Medicine. So I made the decision and left with the full intention of coming back. But things do change. Do you want me to stop here? Is there something you want me to bring? I have a tendency to go on and on.
No, we just lost Lucia, but she is back. But I wanted to ask you, what advice would you give someone that is thinking about changing majors and they're doubtful? Like, should they follow their passion and just go with it, or stick to what the plan they had, especially now that we're trying to graduate students in 4 years? What advice would you give?
So the first thing is know what it is that you want to go into and be realistic about it. I mean, and I don't mean realistic by thinking, I can't do it. Know what it is that you're going to go into. So for example, one of my classmates who graduated a year or two after me from Cal State Long Beach, I was on the admissions committee when his application came through. And when his application came through, he was excellent in so many different ways. The one thing that he didn't have when he was applying to medical school was he did not have any volunteer experience. So I remember sitting on that committee and the committee saying, he's a great applicant, but we don't know that he really knows what he's getting himself into. And if we accept him and then he decides afterwards, oh, I wasn't expecting it like this, and he leaves, we have a hole. We can't just fill that with anybody else. So I'd say find a way of getting some exposure to the area that you're interested in, and not just by talking to somebody, but by going and following them, maybe by volunteering. By volunteering in the clinic, by volunteering with an office, by doing internships, summer internships or projects. That helps you so much, because not only do you really get a good idea of what that area is like, but you also get some real world experience that you can add to your CV. And that makes the company or the institution or the program aware that you know what you're getting into. So you have to sort of try it on a little bit, even though you'll never know exactly what it's like until you're there. But certainly if you feel the need to change your major, then do it, but just know what you're getting into. You don't want to be somebody who changes constantly, but you do have to, life is too short. I'm going to be 60 this year. When I think back to my younger self thinking, oh my God, I'll be 27 when I graduate medical school. That seems so old. And I realized, no. There's a lot of life after that. It's not worth doing something that you're not happy about. It's not worth doing something that wasn't part of your passion.
I got kicked off for a little bit. I got kicked off.
Okay.
Sorry, I got kicked off for a little bit, so I hope I'm not asking you something you've already talked about. But what were some of the major obstacles after you got out of college, and you've done your internship, that you can talk to some of our our listeners, especially those that have been out there already?
So I think that unfortunately, there's a lot of obstacles. And we have to find ways of patting ourselves, of making sure that we have other folks to help us out, because none of us have ever done this by ourselves. I think, one of my first obstacles getting out and getting into medical school, honestly, was the fact that I was a California girl in New York City. My mother's Mexican-American. I was used to my family. I was used to my food. I was used to my community. And all of a sudden, they were making fun of me because I was still wearing shorts in November. And I was like, I'm going to wear my shorts as long as I freaking can, because, and it was hard at first. It's just that different culture. I've learned from that experience, though, that every place I go, I ask to speak to the Dean for Minority Affairs, or, I ask about what the community is like here, because I want to kind of know before I agree to come to a place that I have some of my people around, or even that I can get some of my food. I mean, even in Indiana now, there's this great shop, there's a tamale shop. They make the best tamales. Oh, but we need things like that. And I think the other maybe obstacle you can call it is you will be, how do I say this? Not dismissed, but so you can't tell. I'm 5 feet tall. Okay, I'm not that big. And there are many times when people kind of take a look and sort of assume that you're diminutive just because you're small in physical stature, that you don't have the ability or the capacity to do the big job. And you have to be very proactive about what you can do and to kind of put yourself out there. I mean, I always talk about how, you know, a 500 batting average is super fabulous. Everybody's like, whoa, but that means that guy got up to bat and 50% of the time he struck out. He did not get on base. And we have to be willing to put ourselves out there, even when it doesn't mean we're going to be successful every single time. And I think that's probably one of the biggest obstacles is not recognizing what we can do and putting limitations on ourselves before we get out there. Let me give you an example. So there was a study that was done not too long ago, early 2000s or so, specifically looking at men, women, and their choices of careers. And they looked at valedictorians. So these were valedictorians, the best, smartest high school kids around. And they said, you know, what do you want to be when you grow up, basically? The women picked jobs that paid approximately 25% less than the men. Before they even got out of high school, they were limiting what their opportunities were because they were thinking about, well, I want to have a family, I want to do this. You can do those things. You don't have to limit yourself up front. If we limit ourselves up front, then we don't take the opportunities that come our way. And the more we say no, the less people offer them to us. So I think, you know, some of the limitations are what others put on us, and some of the limitations are what we put on ourselves.
You did mention that just moving from California to New York, I've also noticed in your resume that you've been in Ohio and Atlanta and other areas besides where you're at now. And and you did touch on it a little bit, but so you have to really talk about some of the things you need to know or be aware of when you're moving from community to community.
So one of the things is that, you know, I actually had never anticipated living in the middle. I mean, this was only something you flew over. You know, that was kind of my impression. I was on coast to coast. And in fact, when we applied for residency, my husband and I were then engaged and we're a couple. And so we did a couples match and we ranked Cleveland first and San Diego second. Again, I was thinking, well, I'm going to get back to California at some point. But the one thing I realized living in different places is you have to sort of make your own community. It's not always there present for you. Sometimes you have to reach out. And that included finding friends and creating programs. You know, like, you know, stupid example is, you know, we had a supper club when we lived in Atlanta. That was part of our church, and we just joined. And when we moved to Indiana, we said, you know, something's missing. We missed not knowing people that outside of our work life. So we created another supper club for our church in Indiana. But it was kind of our own way of finding friends and people that you could kind of connect with. And I think we all need that kind of connection. The place you live is just the place you live, but the community that you create around you, the network, the support, that's really what makes it a home. And I think over the years, I've come to understand that, you know, whether we were in Georgia or the Midwest or either coast, home is the community that you surround yourself with.
Theresa, well, what interested you in women and pediatric medicine?
So, you know, internal medicine is a very interesting thing. I mean, I first of all, I got to tell you, I love medicine. Okay, medicine is it's not just a job. It's really a passion and a love because you have the ability to make such an impact. I mean, not only in that person that's in the office with you, but also in the communities that you deal with and the families and the policies and everything else. So internal medicine is basically medicine for adults. Theoretically, we start at 16 and go from there. being a woman in medicine at the time when I graduated, we were approximately 30% of the class. So when I got out, there weren't a lot of women practicing medicine. So it just kind of turned out that I started getting more and more women coming to my practice. And I thought, oh, I better really know a little bit more about women's health. And then I started to have more younger women come. So I actually ended up getting boarded both in internal medicine and in adolescent. So I started at 12 and go up from there. But, and I think what got me interested mostly was the conditions that affect women. And more so now we're getting very involved with the impact of sex and gender. I mean, for example, we know that COVID-19 affects more women than men. Now, partly it's because women are the frontline workers. And as the frontline workers, we're the ones that have an increased exposure. So women are more likely to get COVID-19, but men are more likely to die from COVID-19. And so we're trying to figure out, like, what is that difference? How does gender play that role? Is it because the men have more male-related disabilities, like, you know, they're more likely to smoke or more likely to be overweight or something, or more likely to have heart disease? How does that impact? So that's one of the things that we're really trying to focus on now. But it isn't just about the bikini areas for women's health. It's not just about the boobs and the, you know, and the uterus. It's about everything else. It's about, you know, there's a difference in the presentation of Alzheimer's, and there's a difference in the way medications work depending on gender. We know that heart disease is very different from men to women. And why is that? And how do we kind of look into it? And there are other things that kind of come into play. For example, women have a tendency to use supplements. Okay, so right now, any of y'all listening that are using biotin, I want you to take it and throw it away. Okay, so here's my reason. Biotin has an interference in the lab testing for troponin and for thyroid. Troponin is a measure of heart muscle damage. So if I go into the hospital, if I go into the emergency room worried that I have a heart attack, they draw my blood, they look at it in the lab, and first of all, as a woman, my troponin levels are going to be lower than the average for men, just because of the difference, the way my heart works, and then my heart is smaller. So the level already, I could be having a heart attack, but my level is going to be lower than the men's level. And so there's not going to think I'm having it. But biotin, what happens is that biotin interferes with that lab result. So when the blood is going through the machine, the result is going to be artificially even lower. So when in fact I could be having a heart attack, the lab is going to tell me that I'm not. It also affects thyroid levels. So, I mean, I think these are all things that you know, perhaps isn't necessarily on the cellular level, but is on things that women do that make us more susceptible to disease processes.
So it sounds like if I go to my primary care doctor, they may not have done some of this research or know about it. So we almost have to read up on this stuff. I would encourage anyone on this talk to look at some of your writings and some of your research along with others, because I always like to try to stay ahead of things and even ask my doctor. And I have a female doctor, but I also have a male doctor. So thanks for that advice. We had someone ask about along with your medical school and residency journey, was there ever a challenge or an obstacle that you did not expect or plan for, and how did you overcome it?
Gosh, it kind of, I'm trying to think of all the numerous ones. Which one do I say first? Okay, let me give you an example. I guess I don't always anticipate that people will be as upfront about their own biases. So I had a leader, somebody who was in charge of me, who was upset and commented that, you know, I don't know why we keep hiring these young female physicians. They just go out on maternity leave and it costs us too much money. I mean, really? And my return comment was, you know, one, I don't mind because I've hired them. I know when they're going out on maternity leave. It's a defined date. I know exactly when they're coming back. But what I don't know is when you might have a heart attack. And will you be back the next day? So, I mean, I think I was so taken aback that somebody would be so blatant to say openly their bias against female physicians, that I was really kind of struck. And I think ever since then, we've been fairly proactive about, you know, addressing those things and addressing them right away. And there was another time when I was interviewing for a new position, and we were negotiating salary. And the person who would have been my new chair said, you know, well, Theresa, why do you need that salary? What about your husband? Kind of insinuating that I didn't need that amount of money because I have a working spouse. So I said, you know, what about my husband has anything to do with my salary? But that was part of the impetus for putting together a program that we currently run with IU and across the country called the Negotiating the Divide. Because we know that women physicians and scientists make less than their male counterparts, almost everywhere. In fact, there was a study that just came out in September from the American Academy of Pediatrics in which women pediatricians, even though 70% of the practicing pediatricians are women, the women physicians make $8,000 a year less than their male counterparts. And this just came out in the fall. So, I mean, we know that this is a situation that occurs across the country in every discipline. In fact, the only occupation in which men and women are almost on pair with each other in terms of salary is construction. And why is that? Because construction have unions. So it doesn't matter who you are. You come in at level 1, you are level 1, and this is what you're paid. But in almost every other setting, in every other situation, women are paid less than men. And part of that is we need to be able to understand and to be able to make those recommendations and to ask for it. But at the same time, we have to change the systems because it can't all be dependent on each individual woman. You know, we need to change the system so that, I believe it's in New York and there's another state where you're no longer able to ask, what was your prior salary? Because if you know what my current salary is, then you're able to offer me that lower level rather than the level at which you were anticipating that this position would go for.
Right. And that's across the board, Theresa. I mean, for the males that are on this talk to be aware of it, as well as you said, it's across the board. I was in the workforce in the 70s, which was even worse. And the questions they would ask. And that maternity thing always came up. I had 2 children while I was working. I came right back. But thank you very much for that. We have another question. For those graduating in the spring of 2021, but they don't have a high GPA, do you recommend doing a post-baccalaureate program or doing a master's? Because they say they're very new to this and they've decided to take a path to med school and they're graduating in spring with a bachelor's in health science.
So there's a couple things. One is, yes, you do have to show that you're going to be able to have the academic prowess to get through. And there are a number of different ways of showing that. Most post-bac programs are specifically for those folks who have not done the prerequisites while they're in college. So it wouldn't make sense to go back and repeat chemistry and physics and all that kind of stuff. What it would be helpful would be to consider adding a master's in, just so that you can have the academic prowess. Now, there are a number of different programs across the country. For example, IU has one called MSM. It's Medical Science, Masters in Medical Sciences, Masters of Science in Medicine, something. But basically, it's an additional year or 2 to help get you ready for medical school. And we have had a number of excellent physicians come through that program. And there are a number around the country. The AAMC, which is the American Academy of Medical Colleges, has a listing of not only summer programs, but also of post-bac programs and master's programs. Those can be really helpful to at least show your academic prowess. Now, it's also very, very helpful if you can document why you might be having those difficulties. You know, for example, when I first came out, you know, I wasn't planning on medicine. I wasn't planning on anything in science because you had to study for that stuff. You know, that was harder. I thought I'd just be an actress or something. But so my first couple of years were not that great. And then when I switched, I said, I can't afford to be working anymore. You know, I got a lot of outside grants and scholarships and loans and things to be able to pay. So I didn't have to work because I really needed to spend all my time on my studying. And my grades and stuff had made a marked improvement. Why? Well, because now I had a purpose and a goal. But I also then had to explain that in my personal statement that I didn't come in as a pre-med student, and I was also paying my own way. I mean, that's a lot different than somebody who's doesn't have to think about those things, you know, or somebody who's able to, you know, put them right on the right path. So I think, one, you have to talk about it. You have to explain it, get some advice, take your application to the local school of medicine and talk to the admissions person there. They actually are really good about it. And I'd rather go through them than through a college peer advisor because they haven't been there. You can also use me. What the heck? I mean, with the American Medical Women's Association, we have a pre-med group, and that pre-med group is really there for us to be able to help and mentor. So whatever we can do to kind of help review your stuff. I mean, we'll review your application. I've read personal statements and given advice regarding MCATs and things like that. So certainly, I think that the grades definitely do matter, but what you do on the MCATs, what you do professionally, I mean, and by professional, I mean within the organizations that you might work with, most, especially women, we don't highlight ourselves enough. We're always like, oh, well, thank you, but, you know, I was just the member, I was just the person. And you're like, well, no, wait a minute. You ran a blood drive for your group that was the largest blood drive ever in the history of the school. Well, yeah, but no. That's the kind of stuff we need to know more about. You also have to focus on your letters of recommendation. You want your letter not to say, oh, she was a smart girl in my class. Yeah, no. We need them each to have a different aspect. So it's okay for you as a student, as a pre-med person, to ask your letter writer, I need you to focus on this. I mean, for example, when I went up for full professor of medicine at IU, one of my colleagues, I said, you know, everybody's going to be writing about different things, but I asked her specifically to write on being a minority physician and the impact me being full professor would have. And, you know, the data that we found was that of the 35,000 faculty in schools of medicine across the country, only 21 of them were women of Mexican-American heritage who were full professors. Me becoming a full professor increased that number to 22. That was impactful. And you know, her letter was different than everybody else's letter. So that's one of the things that, especially as you write those letters, you know, maybe you want one of your letter writers to talk specifically about your background. In many of the personal statements that I've read, the major hassle is that you talk about why you want to do medicine, but you don't tell me about you. I want to know about you. I want to know about your journey. I want to know about why you're different than somebody else. And I want to know why you deserve a shot. So yeah, definitely use your organizations, use your colleagues, you know, go take your stuff to the admissions office at, you know, your local place, UC Irvine, UCLA, Riverside, whatever. Take your stuff and say, I'd like for you to look this over and tell me, you know, where I can best, you know, improve, or what would be your advice.
Theresa, can you talk a little bit about how COVID-19 is impacting not just the medical, I mean, we know in terms of hospital and first responders and the frontline folks, but in a broader sense, and then in particular, like you said, in some of the things that you're involved in with women and children.
So, you know, COVID has been a really interesting thing to live through. And I hope that you all are taking an opportunity to write down your thoughts about it, because there has never been anything like this in our lifetime. You know, 100 years ago was the last time something like this happened. So people going forward need to know about your experiences. So with that in mind, you know, there are a number of things that came up. I do internal medicine, mostly outpatient medicine. I do a lot of eating disorders and things too. So I haven't been on the front lines in the hospital in a COVID unit. I was on the list to go. I had volunteered so that way, if they needed me, I'd go, no problem. But it hadn't been used yet, I guess. So almost overnight, we went from seeing 11 to 14 patients per half day to 0, and going from never doing a virtual visit to 100% virtual visits. You know, my family right now is kind of scattered. I have 2 children that live in Atlanta, 1 that lives in New York City, and my husband and I were here in Indiana. And he no longer does clinical medicine, and so we made the decision that he was going to go someplace else. So we also have a place in North Carolina, so he was going to work from North Carolina. So now, as it turns out, everybody's in Atlanta. He's working from home in Atlanta, and all my other 3 kids are all there, and I'm in Indiana. Partly because I didn't know how I was going to spread this if I got it, because I was going to be the one that was going to be seeing patients, and I wanted to keep my family safe. So it was a rough couple of months, and I realized as I saw my son, one of my sons, not too long ago, I kept coming up to him and hugging him, and you know, he's 25 and he's kind of like, Mom, you know, like, let go now. And I said, you know, James, I don't get to touch people, and I really miss that. You know, even when I'm seeing patients, I don't see that many of them, but you know, I used to get a hug from somebody I met on the street, you know, somebody I knew and I hadn't seen in a while, whatever, or, you know, every time I came home, I had somebody to hug, and I didn't have that for a couple of months, and it was strange, and it was hard. So he's just gonna have to suck it up and get hugged a lot. The other thing is we would have these wellness Zoom meetings with the other women in medicine. And on one of those discussions, we started talking about the fact that, you know, we weren't on the front lines. And it creates a lot of guilt. Now, you know, it may just be that women are more guilty. We have a tendency to be guilty about everything. You know, we never do anything well enough. And so as we were talking, we realized, you know, this sense of guilt may be a little bit more unique for women physicians and scientists. And so we actually took that discussion and wrote it into an article, got it published on Kevin MD blog, which is a medical blog, and then it kind of got binged all over the place. And we ended up doing a talk for Side Effects Public Media with NPR that was spread across the country about frontline guilt and the PTSD that's going to be associated with this, and you know, the impact that it has on women. And now we're in the process of writing another article specifically about the impact of COVID-19 on promotion and tenure, especially as it pertains to women. Because, you know, what we're noticing over the last couple of months is the number of articles, the number of submissions for grants and publications has markedly decreased among women. And as I talk to my colleagues, you know, they may be working from home, but they're working from home also teaching the kids because the schools are closed. Also, there's no daycare. Also, there's the laundry. Also, there's the, you know, the house cleaners aren't coming. I mean, it's like all of these things that you didn't anticipate. And that definitely impacts your ability to get your projects done. Or even to the extent that, you know, some of our researchers would bring their kids in with them to the office sometimes if there was a sick day or a snow day or whatever. You know, they'd stick them in the corner while they're doing their work. You can't do that now. They can't come in the hospital, you know. And the research labs are being kind of shut down, and that impacts us all. So, you know, we're going to have to really kind of relook at things. Not only that, I mean, let's think about, you know, we had a meeting scheduled for the American Medical Women's Association. It was going to be the first time in Indiana, a big meeting. We had to switch it to a virtual meeting. So what happens to all those presenters? In order to get promoted, you have to have documentation of scholarly activity and invited presentations. Well, now all of a sudden, the presentations weren't happening, or my students who had posters to present. I mean, so you have to be really kind of innovative to think about how those things are going to still go on and how they're going to be listed on your CV. So yeah, it's had a major impact. I mean, not only in illness and death. One of my medical students, both her and her mother got COVID, not from each other. Her mother just got out of the hospital after 6 weeks, and she's in rehab now to try to relearn how to get her muscles to work again. She survived, my student survived. She actually wrote about that experience and got it published. And, you know, there's just so many different ways that I think we're not going to be able to be aware of. I think, I don't know how you all feel, but, you know, when I go into a store or I go into an establishment and there are other people not wearing masks, it's really distressing. Because I know that when you wear your mask, you're doing it because you respect me. It's not about politics. It's about the fact that you're able to contain the virus to yourself better than without it. And it's really tough because I think about my colleagues who have died from COVID-19 infections. I mean, healthcare workers that have died across the country. We didn't expect this. We didn't sign up for this. We always knew, I guess, that that was a potential that we would come in contact, but somehow or another, it wasn't as evident as it is now. And yeah, I guess I would really like for anybody who's not wearing a mask to have to sign an affidavit to say, if I get sick, never take me to the hospital, don't take me, you know, don't infect anybody else, I'll just die at home. Okay, it's not happening.
Theresa, can I, it's a good segue. We'll come back to COVID because there's other questions on that, but can you talk a little bit about telehealth and your observations on how medicine will continue to evolve?
Oh, sure. You know, well, thank goodness that this happened now, not 10 years ago, 5 years ago. I mean, because telemedicine was really kind of in its infancy and mostly being used for those patients who didn't have access to subspecialty care. So somebody in a rural setting, a lot of the VAs were using telemedicine to be able to contact people that couldn't, you know, people that couldn't get into their facilities. And then all of a sudden, like overnight, boom, we were all doing it. Now, the other big component of this was that, you know, quite honestly, it wasn't reimbursed very well. So if you're not going to reimburse us for doing it, we're going to have a really hard time doing it because every time we do a telemedicine or virtual visit, that means that's time that I'm not seeing a patient in the office. Well, when all this happened and telemedicine and virtual visits became really imperative, you know, things have definitely changed. There's better reimbursement than there had been in the past. We still don't know if that's going to continue. So all of you out there who are going into health policy and healthcare administration, yes, be thinking we need you to help make these policies go forward. Because if in a month or two they say, well, we're not paying for it anymore, it's going to be really difficult. I think there's definitely a role for telehealth and virtual medicine. And so the difference is that one is telemedicine, I'm just talking to you on the phone. Virtual visits, I actually see you. And I actually can see a lot. I've had people do, you know, different kind of physical exam components so I can see what was wrong with their shoulder or their hip or things like that. So I think there's definitely a role for it. My concern is that one, not all the patients have access to Wi-Fi. I mean, we have counties in Indiana where there's no internet access. And even if they have it, a lot of the patients are older. They don't really know how to use it properly. We also have places where, you know, people don't have a blood pressure cuff in their home. And blood pressure is the silent killer. Hypertension is a silent killer. So they don't necessarily know. And so I've been saying, oh, well, when next time you go to the pharmacy, stick your arm in that machine. Well, you know, the machines are closed off because of COVID. So they can't just put their arm in that machine anymore. You know, and they may not have the money to go buy a blood pressure cuff to have at home. So there's a lot of little nuances that we have to figure out. One of my hassles, quite honestly, was in doing eating disorders. The last thing I want is for my patients to be weighing themselves because that 1 pound more or less could just really, you know, be very, very triggering. And say, so what would you weigh today? Oh, you know, can't really do that. So we still have to have some patients come in. There have also been a couple of times where, let me tell you, for example, I had an older patient, new patient, who came in just so I could do her exam and everything. And on her exam, I found she had a breast mass. So how long has that been there? Oh, I don't know. I never noticed it. Yeah, she's got breast cancer. So many times I've listened to hearts or lungs and heard things that they weren't aware that was there. So, I mean, I think there's definitely a role for virtual health and telemedicine, but I think we do have to also do it a little bit cautiously. most of the time it works out fine. And especially for psych, it's been really helpful to be able to have it for our eating disorder patients. But even then, there's a lot of nuances that you kind of miss. At the same time, it's been kind of fun to see the animals in the house, or, you know, to get an idea of where people are living, and to see the dishes piled up, and, you know, and well, the depression must be getting worse because the dishes in the sink are piling up, you know. And so there have been many aspects of it that have been very good. And I'm hoping that it will also allow us to really work on increasing access for those people who don't have it.
I have a question from someone about, let me just read it. With COVID-19, many MCAT exams have been canceled. Will medical school process our applications and granting interviews for this cycle without MCAT? They do plan to take the application by fall.
Right. So the majority of time you will get a interview request if the rest of your application is looking pretty good. In the past, you had to have everything there, all of your letters, all of your MCAT scores, etc. If somebody is pretty good and everything else looks pretty good, they'll most likely extend you an offer for an invite, especially because I think most schools are going to be going to virtual interviews. So I know that we're doing that with all of our residency programs, so it's most likely going to be happening with the majority of medical schools as well. So I think with that respect, it's going to be a little bit less costly for folks, so they may be able to increase that. And they recognize that it's going to be different for everybody. If though you are somebody kind of on the border, if your grades are okay and your experience is okay, and you really needed that MCAT to boost you up to garner that interview, you might be one that's going to be held back. But I would still say you need to get your application in early. Get it in July. Get it in that first week when everything comes in. Having it in early makes a big difference, even if the interviews don't start till September. So let me give you an example. When I was in medical school, I was on the admissions committee, and I wanted to be really helpful and everything. And at first, in September, I would get 10 applications that I needed to review for the week. And I would pore over them and try to look, how can I get this person an interview? And we had a little grid that you put numbers in, and I'd put my numbers in and I'd go back and I'd try to find a way of maybe increasing them, making them a little bit better. By December, I was doing 10 applications a day while I was doing everything else. And I was whipping through those things. I wasn't reading personal statements. I mean, 10 applications a day while you're studying for medical school, I'm whipping through those things. And at one point, I remember this applicant, I put him in the no pile, and all of a sudden I went, oh my God, this guy's from USC, he's got a 4.0 GPA, he's got fabulous MCATs. How did I screen him out? And it was honestly just because, yeah, seen that before. Oh yeah, everybody's got 4.0, who cares, you know? And I hadn't taken the time to really look over his application. But we're human, and that's what's gonna happen. If you really have written a nice personal statement, you want somebody to read it. So put it in early. Don't wait. Don't wait for all your scores to come back to look how beautiful it is. Oh my God, just put it in now. Just put it in now. Put it in, not now. Okay, the deadline's, I think the starting point is in July sometime. But I mean, put it in early, but also use people to look it over. Use people to see if you're really highlighting the things that you want to be highlighting. You know, if you are a member of an organization, don't just write member. You know, put what you did for that organization. And then also think about your email, because everybody has an email. A lot of things kind of get done that way. I want every time you interact with me, and I'm saying me as a staff at the admissions office, whatever, I want me to continually see those things about you that are impactful. So in your tagline, it should say, Theresa Rohr-Kirchgraber, 84, chemistry, president, Chicanistic community medicine. This is my tagline from Cal State Long Beach. So that every time you see something, that I see something from you, it's going to have those leadership things are kind of like be right there looking at me, rather than this is from Theresa, thanks. Yeah, no. Every opportunity you can, you have to show who you are and what you're doing. And the fact that, dang it, you are good. We need you. We want you. You really want me in your medical school, don't you? Rather than, well, I don't know if I'm going to be good enough to get in,
I know we've had You mentioned that you'd be happy to help people out by looking at their applications, and so I think we will be able to get that information to some of the listeners. Someone did ask about community involvement and also why do you think minorities don't seek careers in the medical field? And I think that's kind of broad by minorities, because I know there's a lot of different minorities that do.
Mm-hmm. Well, unfortunately, the numbers of minority physicians has not increased significantly since the 1970s. I mean, affirmative action was meant to do that, and I know that it was helpful. I know it helped me get into medical school, but it hasn't had the impact that we expected. And it's a really difficult thing. I'll tell you, okay, I'll just tell you right now that I think there is still a lot of unspoken racism, unspoken sexism. Sometimes it's spoken directly. But there are a lot of great alternatives for folks. So if you are a very intelligent, well-spoken minority person, you may not want to take the road to medicine because it's a long road and it's difficult. And I think people have found that there are other ways of making a living. Personally, I think it's the best. I love the opportunities that I've had. I like the fact that, if something happens and I get fired, I have an MD after my name. I can do whatever I want. I can hang up a shingle and people can pay me in chickens if that's what they got. But at least, it's different kind of a career than anything else. But definitely I think the support needs to be there, not only once we get to medical school, but all along the way. And that's why organizations like when I was at Cal State Long Beach, the group Chicanos for Community Medicine was so helpful for me, because I didn't know how to fill out an application, what to do, how to get involved with things. I didn't understand that component of it. I think as a physician now, I utilize a lot the American Medical Women's Association, because I need that group of women to, again, help me to learn what the next step is, how to get to the next level. We have to be supportive of each other. We also have to find those networking opportunities. So I'm going to say, one, there needs to be more of us, and that's partly why I'm talking to you all now and why I encourage you, reach out. I mean, this is what we do. Somebody helped me, and my role is to get more of you all into medicine in some way, shape, or form, because I'm going to get old and I'm going to need you. So it's altruistic. It's not necessarily.
Yeah.
And then, I'm sorry, the other half was of the question.
Just the volunteer involvement.
So it kind of depends. I think that volunteerism and advocacy are incredible opportunities and ways for us to keep ourselves involved and decrease burnout. Okay. Currently, I'm very involved with advocacy work because I recognize that there are so many ways that what's been done in the past has impacted my career. So let's just say, for example, reproductive health. Okay. I mean, before the 1960s, we didn't have a pill. I mean, what did we do? I would have had 50 kids by now, for God's sake, But being able to choose when I had my children and how to have my children, I mean, that made all the difference in the world. And I think that definitely is part of the reason why I'm very much a proponent for women to have the choices and for families to be able to make their own choices. Also, if you're going to be volunteering, especially and you're looking for that to be able to put on your resume, to apply for, for medical school or nursing school, whatever you want to do, you have to make sure that it's something that you're going to learn something from. So like I mentioned to my colleague who applied, he was a great guy. He volunteered as a lifeguard and he worked with Boys and Girls Clubs and all that stuff, which was great, but he didn't have medical things that he could point to. So I'd say the volunteering is helpful, especially if it helps you to grow as a person, but also you don't need to do 10,000 hours of it. Do it, get some exposure, be able to write about it and talk about it and go on to something else so that you increase your experiences, but be able to talk knowledgeably about those experiences. So I think definitely having the volunteering is helpful, but don't do it at the expense of your academics either. I remember in medical school, there was a point when I was thinking, oh, I really should, I was always been very involved in things, and it was hard to not be involved in the local church, to not be involved with, local support groups and all this kind of stuff. And I had to keep telling myself, your goal right now is to get through medical school. Once you are done, you will then have the ability to help so much more so than if you don't get the academics in because you're volunteering at the soup kitchen all the time. Yes, those things are necessary. Yes, those things are really helpful. But where do you want to be at the end of your career? You want to be able to have made an even greater difference, and you can get that by completing your education, by completing your degree, and then being able to go back and help even more so.
So I know that when people do contact you, that maybe you can give them some examples of some of the health organizations or medical organizations they can work with for networking as well as volunteer work.
Absolutely.
Right, and I think you did talk a little bit about the timeline in terms of med school applications. I guess they started today, and you're saying probably that July timeframe of getting them in early. Makes sense? So
Absolutely.
I'm not sure if there's any more questions. I know that someone asked about how do you focus on med school, but also help out with COVID and protests. And I think I'm going to let you answer that.
So remember, your number one goal is to get your education. That's the bottom line. That has to be the only thing that matters. When I switched and went to pre-med when I was a student at Cal State Long Beach, I was involved in a lot of things and working and dating and everything else. And there had to be a time when it was like, nope. I had to have a singular focus. My singular focus is I needed to get into medical school. And then I needed to get out. But I think you're always going to have some time for others, those kinds of things. And then if you really feel the need and you want to be involved, then you pick like one thing, Like I said, I was involved with the Chicanos for Community Medicine, and currently I'm involved with this letter writing campaign. It's called Vote Forward. And Vote Forward is a way of encouraging people who haven't voted to vote. And so it's actually registered voters. It's not political. It's not, one side or the other. It's just encouraging people to vote. And so I download these letters, and every time I have a few free minutes, I write a couple more, and they get sent out to people all over the country. I think currently I'm working on some from Michigan. But it's my way of doing a little bit of advocacy in a very small period of time and making like I'm feeling a difference. And that's what you have to find that for yourself. You can't always be the one that raises the soup kitchen and, does the whole thing on your own. We're currently putting together a march for Wednesday. We're calling it White Coats for Black Lives, because there have already been a number of instances in Indiana and at the School of Medicine where racism was not properly addressed. And we feel it's extraordinarily necessary to talk about. So I got things going, but I'm not the lead on it. There's a couple of other folks that are taking the lead, and hopefully I'm going to be there. We actually have to wear our white coats inside out because you can't have the logo. If you have the logo, then that means your institution is supporting it, and that's not the case. So I think wearing them inside out is going to be really impactful. But it's interesting how we talked about this 2 days ago, and it's already on and it's already out there, and people can come out and just come out for half an hour and then go back in, or whatever they need to do. You can't save the world all the time, but you can keep doing your little part. And if that little part means you making comments, when somebody makes a stupid joke, or when somebody makes a joke on Facebook about, and it's off color, for you to address it and go, yeah, no. Or even when we're in a group or in a meeting, and one of my women colleagues made a comment about a certain procedure that she was doing, and a way of doing it. And about a minute or two later, one of the guys said the same thing. And she looked at me like, And so I said, well, yeah, that's just what Angela just said. I'm so glad that you confirmed that. I mean, it doesn't have to be sometimes really big. It can sometimes be very small. But every little thing that you do can matter and can count. And don't discard the things that you do. You are a very important person, whoever you are. And the one word that I hope that we all get out of our language is just. Just is such a negative term. I'm just a medical student. I'm just a college student. I'm just a female physician. No, 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 no. We are none of us justs. We are who we are.
Right, I think we're, Noemi, how are we doing on time? Oh, I can't hear you, but I think we're right at 2.
Yeah, okay, okay. Yeah, well, listen, feel free. I'm very serious. I'm happy to look over stuff or, give words of wisdom. I love that. And I'd be happy to, to meet up with folks. Zoom is always an easy thing. I am going to put a plug in for the American Medical Women's Association. Our pre-med chapter is fabulous, and that division is growing by leaps and bounds. And it's also kind of makes it easier to get that mentoring when we know that you're also a member that we can kind of, reach out to. So, but thank you so much for this. This was a lot of fun. Thanks for putting it together.
Thank you, Theresa. Noemi, how can everyone get the information on Theresa?
Well, thank you, Lucia, and thank you, Dr. Kirchgraber. I was going to ask, do you have a LinkedIn where people could?
Sure. Okay. Sure. I'm on LinkedIn. It's Theresa Rohr-Kirchgraber, and my office email is trohrkir@iu.edu. You're fine to share that. You can also find me through the AMWA website, the American Medical Women's Association, under leadership. I'm the chair of the advocacy committee. So there's plenty of ways to find me. I'm on Doximity, and oh, you can follow me on Twitter. I forgot I have that. It's PT Kirchgraber on the Twitter thing.
Introduce yourselves. Yeah, introduce yourselves as having heard her on this session.
There you go. Absolutely, absolutely.
Right.
Wonderful.
I'd be happy to type the email right now. Here, let's see.
Oh, good.
Wonderful. Well, thank you everyone for joining us today on this latest edition of our 49er chat. And just a reminder, this was recorded and it will be living on our website. Follow us on our social media accounts at CSULB Alumni to learn about future chats. And thank you so much for your time.
Thank you.
Thank you.